So David, we're joined by a special guest today.
Yes, my colleague, and also he shares a wall office with me.
So welcome. I'm thrilled to introduce Zach Kribs, who's been on the podcast before and is our person on Capitol Hill. So Zach, how are you?
Hi, Todd. Hi, David. And Lauren, thanks so much for having me back, and always a pleasure to be with you. It is I'm smelling some jet fumes today. I don't know about you.
Uh, didn't expect you to go there, but yeah, it's definitely an interesting time for those of us who live inside the Beltway. So maybe we can sort of start. I mean, really, what we wanted to focus on today was the appropriations process. So again, this is something that happens annually, where Congress takes recommendations from the president and then makes decisions around programs that have discretionary funding. In other words, they have to be funded annually to continue. And I think we're going to focus mostly on legislation around the Departments of Labor and Health and Human Services, particularly the Department of Health and Human Services, and then education is the other piece of that. But just to be clear, we're on the HHS piece, so that's the National Institutes of Health, that's the Agency for Healthcare Quality and Research, that's the Centers for Disease Control and Prevention, Food and Drug Administration. So a lot of agencies that we spend a lot of time interacting with. So how's that sound for a sort of game plan for today?
Sounds good
I'm
to
all
me.
for it.
Let's just throw Centers for Medicare and Medicaid Services in there too, CMS.
Uh, Um, no, we're not going to, David. I think this is one where we're not even going to mention CMS or CMMI. We're just entirely
Okay.
on labor HHS, but
Okay.
particularly HHS. So David, why don't I start with you, and then I know you've spent more time sort of looking through the proposed the proposals for funding for fiscal year 2025, which, to remind everyone, starts on October 1st of this year. So that's another point here. I guess, David, just historically, as you think about the process, do you feel like this is closer to how things used to work when each of the individual sort of agencies went forward in terms of their funding, and then those were all sort of approved as they came up? Or do you think it's more like the sort of new approach where it's more sort of omnibus, where most things sort of happen at one time, usually at the end of the fiscal year?
This strikes me as being a little bit of a combination of both. It does seem to be a little bit of a hybrid from what we started and what from what we used to see into what we've got now, because it is a lot rolled in here together and it was omnibus. And I did want to say I wanted to congratulate Zach because the amount of discussion of kidney in this bill is quite significant.
Yeah, Zach, that was something I noticed as well. I mean, I did, I haven't done the comparison to previous years, but it seems like some combination of the words kidney, renal, nephrology dialysis are mentioned more than I can ever remember. So congratulations. I guess let's start there. Why do you think there's such a congressional interest on the appropriation side for kidney health?
Well, first off, thank you. And I think the thanks really goes to ASN's members and our leaders on the Policy and Advocacy Committee and Council who have really prioritized advocacy efforts with Congress, particularly as it relates to appropriations. I think this is really a direct result of two things. I think it is a direct result of our advocacy on the Hill and the advocacy of many members of the kidney health and transplant community. You really need this kind of sustained pressure to bring things to Congress's attention. Rarely, as you're both very well aware, does something happen kind of on your first pass. But it takes a couple of years and months to really build this narrative and get the attention of lawmakers that can result in this incredible momentum. I think the second big reason is just the impact that kidney diseases have in the US. Kidney diseases are estimated to impact 37 million Americans, and more than 800,000 Americans have kidney failure. That represents a sizable percentage of the federal budget. Medicare spends annually more than $50 billion managing the care of kidney diseases, or kidney failure, pardon me, and then closer to $150 billion managing kidney diseases overall. That's about 1% of all federal spending. So there is a reason from a financial perspective that Congress is interested. I also think there's just a human interest too. I think we often like to ascribe financial motivations to Congress, but I think anytime we as advocates can align doing the right thing for patients with also being the right thing from a fiscal perspective, it's always a killer combination.
Yeah, it's interesting. Senator Dirksen, who the Dirksen Senate Office Building's named for, once said $1 billion here, $1 billion there, and pretty soon you're talking about real money. And so I do think that is one of the aspects of this. This is real money, and it's gotten people's attention. David, kind of curious as to your perspective of both Senator Dirksen. I think you may have been on Capitol Hill when he was still in the Senate.
Yeah, well, actually, I was a very young staffer. I'm not going to say how many decades ago, but it was, when I actually sat there and I was actually carrying somebody's briefcase, to be honest with you.
Yeah.
But nonetheless, Zach, I mean, I'm looking at this, and by the way, Zach, they actually are now landing on the idea that 25% of Medicare's annual budget is spent on people with chronic kidney disease. I don't know if they're factoring kidney failure into chronic kidney disease there. I'm imagining they are, but they have a real sense. I mean, look, they are talking about chronic kidney disease prevention. They're talking about what is wrong in terms of reimbursement for organ recovery and for living organ donor reimbursement, and also just the cost of excuse me, and then other pieces, excuse me, and then the whole organ procurement organization and whether or not HRSA gets fully funded there. So there's a lot there. And then you've got their instructions in IDDK and instructions having to do with workforce issues and medical student education. That is like all over. They are seeing pieces of kidney. Wouldn't you agree?
Yeah, and then I'll tack one more onto that list. ASN specifically asked for language around kidney health innovation. We run the KidneyX Innovation Accelerator for 5 years now. And I think as we're looking towards the next iteration of that program, we felt as a policy operation at ASN, it was really important to kind of build this next chapter of innovation support. And so we actually also saw language directed towards ARPA-H, highlighting the progress of KidneyX and the potential that exists for programs like ARPA-H to kind of pick up that torch and bolster KidneyX's efforts.
Well, I mean, I don't mean to make too big a deal about this, but having been with you, working with you for many years now, a good portion of this looks like our talking points. They look like they come straight out of the things that we ask our members to say when we go in. And to really kind of, and they also even did address our issue that we've been talking about, the retrospective trend adjustments in the comprehensive kidney care contracting part of the model, KCC model, which has been rather contentious. Wouldn't you agree?
Absolutely, and I knew you'd figure out a way to bring CMS back into the conversation. I think, again, right as I said at the top of this podcast, this really does speak to the leadership that ASN and ASN members have had in congressional advocacy. I think ASN also needs to congratulate our partners in the kidney health and transplant community too. I know, for instance, the National Kidney Foundation was really worked a lot on some of the language around chronic kidney disease management, both for the CDC and for NIDDK. And our work in partnership to help set a new course for kidney health, I think, is a very important piece of this as well. But this really does reflect years of advocacy, and I think we're starting to see this come to fruition. Now, I do have to caution that report language itself is not going to change the game. I think it's an important tool, but what we really need is actual funding to be passed, which I think takes us into the future of this appropriations bill, and then probably the future of the next Congress.
I agree with you. It is true. That's not the same thing as the statute itself, but it is. It has been relied upon a great deal for a context of conversations. It does not represent exactly the same thing as statute when the courts are looking at it, but it is creating a large record with some very clear indications of what Congress is looking at. And there's a lot of, there's actually a very strong focus here on actually also the disproportionate populations, the disproportionate burden on certain populations, particularly African Americans. And this is just really kind of just amazing that in this kind of really contentious period, that this could come out bipartisanly from a committee.
The LHHS bill as a whole cut health spending by $8.6 billion, or about 4%. So this is a bill, and that's compared to the previous year's enacted funding. So this is a bill that is not friendly towards health funding. The fact that there are 8 distinct pieces of kidney health report language and increases to the programs that ASN has called for increases for, whether that's the NIH, whether that's HRSA and their organ transplant program activities, both for the modernization initiative and for better supporting living donors, I think really does speak to your point to the bipartisan progress we've made in this space.
Yeah, no, it is very striking, and I'm going to be kind of critical of my own self. I've been here long enough that I know when I look at this, that this takes a long time to accomplish, that this does not happen, like you said, in the first year, in the first pass. And I think ASN has been really working very hard on this, and I think you have been working very hard on this, and it really shows, and it makes me excited. And yes, I do talk about CMS all the time, but there's a lot of stuff in here that I'm glad to see. They are basically telling CMS and other parts of the executive, you need to focus on this.
So I have sort of 2 unrelated questions, and let me do the easy one first, and then I'll do the hard one. So David, let me ask you, I mean, an observation you made to me recently, since you mentioned CMS, there seems to be a shift where historically, when we've thought of nephrology, and particularly when we've thought about kidney failure, it's been phrased as ESRD because of the ESRD program. And there's been a little bit of conflation there. We can go back to the Supreme Court decision on Marietta, which is a good example of that conflation. But it sounds like both in the legislative branch and the executive branch, there seems to be a understanding that there are kidney diseases. There's kidney failure. Kidney failure relates to dialysis and transplant, that it's a much more complicated ecosystem. Can you just sort of talk about that a little bit? And then I want to go to Zach with the question that's probably an unfair question to ask him at this moment.
Well, I'm going to do a real small example, but I want to do it fast. And I think I spoke to you recently about this, which is we finally got the government to agree to consider different sites of care for people being discharged from the hospital with AKI, acute kidney injury. And the important part to that is that they would be able to be discharged to home if the doctor and patient agreed. To do that, CMS has got to go back and change the conditions for coverage for dialysis facilities. So for the first time, since this has been going on for quite some time, they will be changing the conditions for coverage to say not for treatment of people with ESRD, but treatment of people with kidney failure. Because they realize it's not that simple. It's not that exacting. Many people with AKI have some underlying kidney disease, but before they do go into the hospital. But at the same time, it is a recognition that this is not something that a simple terminology of a program can work for it. And so,
David, I know Lauren and you are currently working on the physician fee schedule, the proposed rule. Anything you'd like to add, either of you?
Well, I will add one thing. We were delighted to get something that we had lobbied for very much, and that is we've got coverage for dental care for patients who have kidney failure will be included now. And so that was something we very much really wanted. But I would just say to what Zach was saying into this whole conversation, it is a hot one. It is a hot summer in DC this year. There's no doubt, both physically hot outside and just a lot of things happening. But it is not a sleepy summer, not at all. There's a great deal happening.
Thanks, David and Zach. And Zach, I know you have to run to go back up to Capitol Hill, so keep doing what you can to help us out and advocate for the community.
Keep up that good fight. Thank you all.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.